Listen-only mode.
Hi, good morning. I am Sirisha, and we are here today to learn about ICD 10, what the code set is all about. And before I begin, I'd like to thank Eric Southard at Indiana State University for giving me this opportunity to, train his faculty and his students. A few housekeeping items before we begin. Uh, the approximate duration of this webinar is going to be about 40 minutes, followed by a 10-minute Q&A session. We will spend the first half of the webinar understanding the ICD code set and what makes it different from the ICD-9 code set. So what makes the ICD-10 code set different from ICD-9 code set? And then why the second half of the webinar will be I'll try to give you insight on why it is important for you as healthcare providers, clinicians to understand this difference and what changes you need to make in your documentation to make it more compliant and accurate with the ultimate aim being better patient care, right? Okay, now without further ado, let us look at our agenda for today. So we're going to do a brief overview of ICD-10 and ICD-9. Then we'll quickly discuss the benefits of ICD-10. Then we'll look at the structure of ICD-9 and ICD-10. Understand the key concepts of ICD-10 like specificity and complexity and things like that. And do a few case studies on the complexity, specificity, laterality, and combination codes, followed by uh, documentation, compliance, and what needs to be done so that your documentation stays compliant. Okay, now, what is ICD? So ICD stands for International Classification of Diseases. In the United States, we use ICD-9-CM, which is customized for use here. Now, even the customization, it is approved by World Health Organization, and the reason World Health Organization uses this code set is to primarily keep track of morbidity and mortality statistics over the world, like how many people are suffering from what disease in which location and what is the mortality rate from the specific disease. So they collect all of this data from all over the world and then make decisions on healthcare. So in the United States, we have modified the ICD-9 to suit our context more. And with the ICD-10 too, we have done the same, which took a few years to modify. I think it took 7 years to modify the ICD-10, the World Health Organization ICD-10 to ICD-10 clinical modification for United States. Now, it is an understatement to say ICD-9 is outdated because the code set itself is 30 years old, and most of the developed countries like Australia and most of the European countries, they've all moved to ICD-10 in the 1990s, right? So we are 20 years behind in the game. Now, finally, after a few roadblocks and postponements, we are making the switch to ICD-10-CM on October 1st of 2015. And it's not an understatement to say this is the biggest change the healthcare industry has seen since Medicare, right? We have not made anything of this magnitude just because of the wide and broad impact this is going to have on the way we do our documentation, the way we process our claims, submit our claims, the way payers are going to adjudicate those claims, everything. Okay. So now I'm not really going to talk about the revenue part of ICD-10 or how it's going to impact uh, healthcare facility revenues, but it does, but we're not going to discuss that. We are strictly going to talk about the code set and what you need to do as healthcare providers to improve your documentation to meet the compliance standards. That's the focus of our webinar. Okay, now how is ICD-10 different from ICD-9? Right, so just the sheer number of codes. So with ICD-9 Volume 1, Volume 2, Volume 3, we have about 18,000 codes altogether, right? With ICD-10, just in the clinical modification, which the clinical modification, the first part, the ICD-10 CM is used in all outpatient settings, right? And ICD-10 PCS, that is the procedural coding set, is used in inpatient settings, for surgeries and all the inpatient stuff. So with ICD-10 CM, we have 68,000, right? ICD-9 only had 14,000. And with ICD-10 PCS, we have 87,000 codes, whereas with ICD-9 Volume 3, which listed all the procedural codes, it was only 4,000 codes, right? So this obviously translates to more complexity and specificity. So you can imagine why we are stressing on documentation here. Now, the ICD-9 codes were a minimum of 3 digits going up to a maximum of 5 digits. With ICD-10, minimum of 3 digits going up to 7 characters, right? So, but both of them have a decimal point after the first 3 characters. But with ICD-10, all the codes are alphanumeric, and ICD-10 also has this unique little feature called a placeholder, a dummy placeholder. So we'll look at what that means in our following slides. And the 7th character is always alphabetic in ICD-10. In ICD-9 too, we had alphanumeric codes, but only 2 chapters. So one is the history and conditions affecting, or historical conditions, things like that. Status codes. We call the V code status codes. Only those codes began with a V, and then the accidents and the poisoning, that chapter began with an E. So other than that, all the other chapters, the codes were pretty much numeric and not alphanumeric. Okay, now let's compare the structure of the code set. So why do we have 7 digits instead of 5? What are the added features here? So now with ICD-9 structure, the first 3 digits represent the category, which specific body system is this code representing. And then the following 2 digits or 2 characters represented the cause and the location. Okay. Now with ICD-10, we have 2 additional components. One is the severity and the other one is the extension. Now when I say extension, this needs more explanation because even experienced coders are getting confused with this. So we'll discuss that in a little bit more detail. So we have category, cause, location, severity, or etiology, anatomic site, and severity, and then the extension. So now before, if a patient walked in with a fracture of shaft of clavicle, you could just put in your documentation, yeah, patient has a closed fracture of shaft of clavicle. And then the person who's responsible for coding, they would just, okay, 810.02, that's closed fracture of shaft of clavicle. But now you can't do that because there is no code that just says closed fracture of shaft of clavicle. The diagnosis has to be documented to the greatest level of specificity. So you want to tell, or you want to mention in your documentation, that this is a displaced fracture of shaft of clavicle, of shaft of left clavicle, because laterality is another added component. You have to tell which side or which location of the body is affected by this. And then you also need to tell whether this is an initial encounter, or is this a follow-up encounter, or is this an encounter for a complication. That's where the extension comes in. It basically defines what kind of encounter it is, and it doesn't mean the same thing across all chapters. The 7th character means different things in different chapters, and in the chapter For musculoskeletal, particularly fractures, the extension means the type of encounter, whether it's a sequela, whether it's a subsequent, whether it's a complication. That's what the alphabet denotes, right? Okay, yeah, as I was telling, it's used in some chapters and it has different meaning depending on the section where it is being used. Okay, now some of the other chapters where the seventh character is used include pregnancy, childbirth, puerperium, and then poisonings and accidents and fractures, of course. So these are some of the chapters where you will, or some of the areas where we'll encounter the seventh character extender. Okay. Yeah, here we come to the placeholder X, right? Now, we all know what a placeholder is, but how does it figure in a medical code? Now, there are some diseases that have not been defined to that degree of specificity, right? So in those cases, what we would do is we would substitute it temporarily with a placeholder X. Normally, the placeholder X would be used either as the fifth or the sixth character, and it allows for future expansion. Now, we have a couple of examples here. One is adverse effect of calcium channel blockers, initial encounter. In this case, if you see the fifth digit, which is the location, right? Fifth digit denotes the location, is not defined. Because adverse effect of calcium channel blockers, what location, you cannot really define the anatomic site or location for adverse effect of calcium channel blockers. So, at this point it's not defined. So we put an X there, right? Same thing with foreign body in cornea, left eye, subsequent encounter, right? In this case, severity, I mean, foreign body, severity, foreign body is foreign body, right? In the left eye. So at this point, the severity of this condition is not defined, so we just replace it with an X in the sixth character. So, we have more examples like this where the some of like the fifth and sixth character are not yet defined. So we just use the placeholder. This is not case sensitive, and being clinicians, this is not actually relevant. It's more for the coders who need to understand the case of the letter when they submit the claim. Okay. Now, here is, oh, okay. Now, let's look at some key concepts of ICD-10 before we move on to our other case study examples. Now, when you're doing your documentation, it could be a good idea to just print this out depending on what kind of patients you see, to kind of just keep your eye on these concepts. So your documentation should include all of these depending on the condition you're treating. Temporal factors, you want to mention whether it's acute, subacute, sudden onset, whatever it is. The temporal factors, the causality, symptoms, manifestations, and findings, the location, the anatomy, if this condition is associated with something else, the severity, the episode, right? And if remission status, and if there is a history that relates to this or somehow affects this, the morphology, what it's complicated by, if there is an external cause like some allergen or like a peanut allergy or a bee sting, whatever, if there is an external cause, and then any activity that brings this condition about, place of occurrence, if there was loss of consciousness, and so the list goes on, and depending on what you are treating the patient for, you should get in all the details, all the key concepts relevant to it, because these are the concepts that all the ICD-10 codes cover. And unless these are defined to the correct level of specificity, it would be hard for a medical documentation specialist to really assign codes. Okay, right. Now, let's look at a few examples for increased specificity. I've been going on about increased specificity. So let's look at what it actually means. Now, most of you, if you have worked in a skilled nursing facility or any nursing facility for that matter, you must have come across patients with pressure ulcers. And what the component that you might not have realized, which coders struggle with all the time, is with pressure ulcer, if I have to get the nurse practitioner paid, I need to report both the location and the stage of the pressure ulcer. It will not get paid if either of these codes is missing. Both have to be on the claim. So as it is, it was a little hard. It was just 15 codes, but we always needed information on the stage. And if it has not been staged, we needed to know that as well. Now with ICD-10-CM, these 15 codes become 125 codes. So in addition to the location and the um, stage, um, before it was broad location, but now the location becomes more specific, right? Location becomes very, very specific. And then we have to define the depth of the pressure ulcer. So imagine if there were 15 codes before, there are 125 codes now. That increases our choice so much. So if the clinician doesn't document it clearly enough, we'll be at sea. We won't know which code to pick. Okay, now let's look at another example, increased complexity. Now, one of the interesting things about ICD-10 is they have changed the core definitions of some of the most commonly used diagnosis codes or some of the most commonly treated conditions. For example, with hypertension, um, from the beginning of ICD-9, from the time we started documenting codes, it was always either benign or malignant. Okay, but that concept doesn't exist anymore. We just have essential hypertension and then secondary hypertension and the causal relationship. So if it's essential hypertension, does it have a related renal condition, heart condition, pulmonary condition? That's all. So benign and malignant essentially don't exist anymore. Okay, so and since with hypertension, most of the conditions that are caused by hypertension, they are comorbid. So we would be using something called a combination code. I can't just say hypertension one code and then heart failure another code. They are comorbid, so your documentation would have to show the relationship, right? The causal relationship between both the conditions. That if the patient say has heart failure, you need to show that, okay, this is because of patient's long-standing hypertension and whatever other causalities are there. Right. And one more example for cardiovascular system. So before, the acute period for myocardial infarction was 8 weeks. So if a patient presented to the clinic and he has had an MI in the preceding 8 weeks, he would be considered acute, right? But now that period has been shortened to 4 weeks from the time of the incident. Okay. Um, so, and then you also need to define the type of infarction the patient had. This was not so defined before. We could just, go with straight myocardial infarction, acute myocardial infarction. But now we need to define whether it's an STEMI myocardial infarction and of which artery, right? So is it the left anterior or, is it the interior wall? So even within the heart, which specific location was affected by the MI, right? And whether it's STEMI or non-STEMI or, so all those details need to be in your documentation. And that will help the documentation specialist pick the right codes. Now, I understand that most of you will not be documenting to this level of specificity, but it's a good idea to understand how this works. Okay, next. Let's look at neurology. This is something, as family nurse practitioners, most of you must come across this all the time, migraine. Now, with migraine, there was only one code before. I know, hard to believe, but there was just one code which said migraine, unspecified. Um, that's about it, right? The only other detail we could include was probably whether it was intractable or otherwise. But now that one code has become 10 additional codes and it defines whether the migraine is with aura, whether it's a menstrual migraine, hemiplegic migraine. So pretty much, all the manifestation symptoms and everything that goes with migraine, that is defined. So when, again, you do your dictation or you do your documentation or you put on your EMR, you need to mention all the coexisting conditions or causalities. Okay. Okay, increased specificity. One more example. This also is something that you must come across often. Pain in limb, most unspecific code, pain in limb. And actually, there was a code for this, and we used it a lot of times where the patient came with pain in, and the coders were kind of impeded here because the clinician would mention where the pain was, but a code just didn't exist, which kind of pointed to the location of an unspecified ache. So now um, that dilemma is resolved because we have 32 codes which relating to extremities, and they define whether it's the right arm, left arm, going right down to fingers and toes, right? So anyhow, in my experience, clinicians have always done a good job with documenting pain because patient would never say pain in limb, right? They'd point to where the pain is, and ICD-9 just didn't have that definition for unspecified pain, but now ICD-10 does. Okay. Now, here is another code where it has branched out. So with Alzheimer's disease, we had one code before, just Alzheimer's disease, 331.0. But we know better, right? There is early onset Alzheimer's, there is late onset Alzheimer's. So how can you just say Alzheimer's? I have to tell what type of Alzheimer's this patient has. So we have three codes now which define this, right? And this will probably expand more as we learn more and more about this disease, and ICD-10 will allow for that expansion. Okay. One more example, one of the chapters that has had maximum number of changes is the cardiovascular system. Because I guess because of the all the advances we've made in the last 50 or so years in that sphere, the codes have to reflect that. Now, when we spoke about atherosclerotic heart disease of native coronary artery, we had one code, right? We had one code for native coronary artery and one code for grafted artery, and a few subsets. But with ICD-10, the ASHD has to go with the symptom. Like if patient has angina pectoris because of ASHD, then there is a single code and it has to go with that. And even the angina has to be defined to the proper level of specificity. What type of angina is it? Is it unstable? Is it with a documented spasm? Is it some other form of angina which is ill-defined, or is it just unspecified? So you would need to understand from your patient and document the proper code for that too. Okay, added laterality. This is simple enough. So anytime there is a condition that involves a specific side, laterality of the body, you just need to include that. Cancer, so if it's, for example, breast cancer, you need to mention which quadrant it is. Is it the upper right quadrant, upper, lower quadrant, where it is. Same thing with cerebral infarctions, pressure ulcers, arthritis, injury, dislocation. So anything, whether it's left or right or upper quadrant, lower quadrant, you need to mention all of those things. And these are some of the areas where laterality applies. Okay. Some more examples. So, neurology. Now, benign paroxysmal vertigo, again, common condition. Before we had one code for positional vertigo, benign paroxysmal positional vertigo. We had one code. Now we have two additional codes, whether it's in the left ear or whether it's in the right ear. So, I mean, I think when you compare it with the other components, that's the specificity and the complexity and the change definitions, laterality is a relatively easy concept for someone to just start including when they document the patient's chart. Okay. Now let's look at combination codes. So I have covered this topic as we were discussing, cardiovascular and neurology before. So anytime there are comorbid conditions, uh, it is the clinician's responsibility to always um, uh, be explicit about the causality. Like if angina pectoris is not a standalone condition. What is causing it? Okay, it is being caused by the ASHD, right? Somebody just doesn't have retinopathy. Okay, patient must have diabetes. The retinopathy is caused by the diabetes, right? So mononeuropathy, again, this is caused by diabetes. So always the condition that is causing the symptom or manifestation, they have to be linked together. The primary condition and the manifestation. The causality has to be shown in your documentation, and that is how the code also will be. I cannot put two separate codes saying there is unstable angina pectoris and then there is atherosclerotic heart disease. No, it has to go together. Okay, so these are some of the combination codes, and I think diabetes probably has the most number of combination codes because you have diabetes with renal manifestations, with ocular manifestations, neurological manifestations, so whatnot. And you have a large number of combination codes. Same thing with hypertension too. And then if a patient has diabetes, heart disease, and hypertension and renal disease, you need to pick that code which denotes how these things are relating to each other and which is causing what. Okay, so as long as your documentation reflects that, the person who is actually doing your documentation and assigning the codes will be able to do a more accurate and compliant job. Okay, so this kind of concludes the first half of our webinar where I have explained to you about what ICD-10 is, why it is used, how it is different from ICD-9, what are the added key concepts with ICD-10, and how you should keep a close eye on what you're putting in your patient chart so that when your chart goes to a specialist or another provider, they get a complete understanding of what's going on with the patient. It coding, ICD-9, ICD-10, everything, it's all ultimately about good patient care. Okay, so now let's look at documentation compliance. Right, so poor documentation has a direct impact on patient care. Why? Because if you're not documenting all the conditions the patient has and his entire history, then information is being lost, which has a direct impact on the medical decision making, yours as well as the physician or the next healthcare provider who's going to take care of this patient. And patients deserve good documentation, right? And from a revenue standpoint, which I'm not really covering in this webinar, it has a direct impact on how your claims get paid. Okay, so accurate diagnoses are important for billing accuracy, quality measures, population management, risk management, healthcare analytics, and patient care. They have a direct impact on all of these aspects, right? Now, why is documentation important? Like I said, it ensures accurate measures of quality and efficiency. It improves accountability and transparency. It captures level of risk and severity. It provides better business intelligence. It supports clinical research, and it enhances or improves communication with between hospitals, between healthcare facilities, within the hospital, within providers, right? And ultimately, all of these have one outcome, which is it improves the quality of patient care. Now, and I have heard this enough and more, that healthcare providers feel, I'm so busy documenting things, I don't feel like I've engaged the patient enough. I feel it's affecting the quality of my encounter with the patient. But then, yeah, it maybe it is true, maybe it's not, but it is documentation cannot be considered an unnecessary burden, because unless there is good documentation, there cannot be good patient care, right? Information cannot get lost. Uh, you might do a good job, you might get all the patient history and give him the right medication, but when it is not put down on record somewhere, that information is lost, right? So accurate, compliant, comprehensive documentation is very, very important, because patients deserve to have accurate and complete documentation of their conditions, right? Okay. Now, let's. I thought it would be a good idea just for you to get a sense of where this entire coding thing figures in your patient interface. So this is how it is, right? So patient comes in, they do an external record review, whatever records the patient has brought in. You take your history, you do the physical exam, you do the internal record review, you order some studies, and then you reach your assessment and diagnosis, right? At that point, your super bill, I'm assuming most of you would have seen a super bill, which is, it lists out all the conditions that are treated in your healthcare facility. If you are um, um, a family practice, right? You would have all the common conditions, like your list of all the vaccinations that you do at your facility, all the common healthcare conditions like sinusitis and headache, migraine, backache, menstrual cramps, whatever, all your common conditions, and their diagnosis codes would be listed on a super bill. And then you will just mark these conditions, and your back office takes over there. They'll actually review the super bill and then assign the codes, and usually it comes back to the healthcare provider for approval and signature. Right. Now, this is how a traditional super bill looks, but it's not possible to have super bills anymore, because here is an example. We had 32 codes for fractures of the radius. We now have 1731 codes. So you can imagine it's just not feasible to have a paper that lists all possible conditions, right? Your documentation has to be good, and then your coder can go through your documentation and pick the appropriate code. Okay. Now, it's not that hard to improve your documentation, because you have been taught all these things when you went to medical school, right? So first you document your type of condition, and then you document the onset. For example, if it's diabetes, is it type 1 or type 2? When did it start? What was the cause of it? Like in this case, are you overweight? Do you have a history of diabetes, right? And if it is some other condition like a sinusitis or a pneumonia, right? You figure out, okay, what is the infectious agent, or what is the physical agent? Is it internal failure? Is it congenital, right? Depending on the condition, you figure out what the etiology is, and then the anatomical location, right? So as long as you ensure that you are covering all these aspects in your documentation, which you anyhow learn, this is how you are supposed to document a condition, right? So as long as you kind of keep your eye on all these key concepts, your documentation will be compliant. You don't even have to put in any effort. You just have to, your focus has to be on being as detailed as possible. That's about it. So anatomical location, the laterality, the severity, any environmental factors that are affecting this condition, right? And other parameters like time, comorbidities, manifestations, healing levels for things like fractures and injuries, any findings and symptoms, external causes, and the type of encounter. So type of encounter meaning if patient is coming for a follow-up visit for a fracture or follow-up visit after surgery, or so you need to just document what type of encounter, or if the patient is just coming to establish herself as a new patient, right? So you need to include that too. Let's do a case study, and this again is a very common condition that you would encounter in um, a family practice setting, otitis media. Okay, now you all know the types of otitis media: serous, suppurative, tubotympanic, aticoantral, allergic, mucoid. There are also alternate terms for this, right? Sanguinous, seromucinous, exudative, secretory, catarrhal, blah, 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 right? So now when a patient comes in with otitis media, you should try to use these defining concepts, right? What type of otitis media it is, and you have this entire list to pick from, right? So just define what type of otitis media it is. And then once you define it, you need to tell us, is there rupture of the tympanic membrane or not? And is there an infectious agent involved? Now, if it is an adult, does the person smoke, right? Or do they have exposure to tobacco, environmental tobacco smoke anywhere? Do they have any, is there an allergic component to it, right? And then the temporal factors. Is this acute otitis media? Is it subacute? Is it chronic? Is it recurrent? And is it in both the ears or just one or the other? These are standard things that you would do when you treat a patient with otitis media. Now all you have to do is ensure your patient chart reflects all these things so that we pick the correct code. Okay, because that is the only way you can keep track of the quality parameters when you assign that code. Now let's look at some examples. There you go. So you have measles complicated by otitis media, serous otitis media, other acute non-suppurative otitis media, recurrent right ear. So I'm sure you're getting an idea why I'm trying to say that you should include all of those components, because this is how the codes are. And if you just told me it's mucoid otitis media, I don't know what to pick. Is it the left ear? Is it the right ear? Is it chronic? Is it acute? Is it sudden onset? Right? So, which is why all those concepts have to be included. Right. Okay, a little comic relief. So, most of us thrive on vague objectives, but unfortunately, it won't just cut it with medical documentation. We cannot do that to our patients. We have to get specific. But obviously, there are cases where we could be unspecific. And what are those cases? Okay, now first let's look at the definition of unspecific. Okay, coding that does not fully define important parameters of the patient condition that could otherwise be defined given information available to the observer and the coder. The coder is dependent on the clinician. The coder can only do as good a job as the clinician does, because they cannot conjure codes out of nowhere. It has to be in the documentation, then they can pick the right code. Okay, so now when the clinician is being unspecific, the coder is forced to be unspecific. Okay, but in some cases, you don't have a choice. It is okay and acceptable to be unspecific, and these are a few of those scenarios. Patient may be very early in course of evaluation. Okay, the claim may be coming from a provider who's not directly related to the diagnosis of the patient's condition, right? Like, if a patient has a skin rash, pretty bad skin rash, but he is, say, seeing a neurologist, and this is completely a dermatology rash. It doesn't have a neurological component. So then the neurologist could afford to be unspecific about the rash the patient has, right? So the clinician seeing the patient may be more of a generalist and not able to define the condition at a level of detail expected by a specialist. So in your line of work as family nurse practitioners, I'm sure you are more generalist, but then again, even within that sphere, like I said, otitis media is something you deal with. You have to be specific there. Migraine is something you deal with. You have to be specific there. And then the more comprehensive, say cardiovascular conditions, things like that, it's okay for you to be unspecific because you're not a cardiovascular specialist, right? You are more of a generalist, right? Now, in summary, we have reached the end of our webinar, and I think I've kept to our schedule. ICD-10 will have a substantial impact on how we define the patient condition for a wide variety of purposes. So as clinicians, forget about coding, forget about everything else. It is good patient care to keep a comprehensive track or to maintain a comprehensive chart of all the conditions the patient has when they began, how they are interacting with each other. That is just for good patient care. And with ICD-10, since the coders have to pick the codes to keep track, you need to ensure that your documentation has all of these things. And from a revenue point of view, it really changes how we do business, because if we submitted unspecific claims, the claims would not get paid, right? And as I said, the requirements for good documentation have not changed. It has always been a prerequisite for a clinician to maintain good documentation. That has not changed. It has just become compulsory now. Mandatory. You have to have good documentation. And ICD-10 codes can support much better definition of the key parameters of the patient condition, and complete and accurate documentation of important clinical concepts of the patient's condition is a requirement for good patient care. Better data translates into better understanding of diseases, which will result in efficiency, effectiveness, and quality. And this again, changes in payment models will leverage the key medical concepts defined in these codes, right? So this concludes our webinar on ICD-10. I hope you feel like you have learned something, and we are now ready for the Q&A, right? So just let me know if you have any questions at all. You can type your questions in the questions panel. You should be able to view that on your GoToWebinar panel. Okay, yeah, all right. Yeah, go ahead, Eric. You can ask your question.
Thank you very much for the overview. I wanted to talk through a couple different scenarios and see if you couldn't help me with how they would have been coded previously versus how you would code them now. So I may put you on the spot a little bit, and that's not really my intention. Hopefully you've got some resources at your fingertips there where you could assist. So before, if I had a patient encounter, let's say, I don't know, a teenage boy that comes in for an initial visit of closed fracture, the left forearm from a fall, I could have coded that as, I believe it was like 813.80,
Mm-hmm.
and it was pretty much fracture forearm, nonspecific, closed. Whereas now, I mean, if that was the only thing the patient was presenting for, can you help me get to what the ICD-10 code would be, like the 7-digit alphanumeric or 7 alphanumeric characters for that specific visit?
Okay, so first with the code, I would need to look up the code, but what you definitely cannot do is just say forearm. You would need to mention which bones in the forearm.
Okay, so
Right. So
let's say
whether it's the radius, whether it's the humerus, whether it's, whatever, not the humerus, obviously, whether it's the, radius or the ulna, you would need to mention which bone in the forearm is broken. That's
okay.
one thing. Okay. And now closed fracture of, now which bone would you say is broken?
Let's say radius.
Radius. Okay. Closed fracture of radius, and is this distal or is this proximal, or where is it?
Let's say distal.
Yeah, so you're getting the concept, right?
Right, yeah. So it is very, very specific.
Yeah, you couldn't get away
So
with saying forearm. You have to say which bone and then where. And you have already said it's an initial encounter, so we would look up the code based on this, either in a ICD-10 code book. So most coders, except for the diagnosis they use like every day, it's hard to memorize. You saw there are 87,000 codes with the PCS and 68,000 codes with um, the standard clinical coding. So normally what we would do is we would look at all these components, refer to our big book. Maybe you know what, I should just show you the images of the books. They are really huge books. Each one weighs about 6 pounds.
oh wow.
Yeah. So we would actually look at the correct chapter, look at all these components, and come up with the right code. Right now, I could look up the code for you. So we are talking about distal fracture. Oh, which is it, the left arm or is it the right arm?
Left arm
Okay,
radius.
okay.
And we'll say it's from an accidental fall.
Okay. So that would fall under the S52.5 series. Okay, and then let's look here. So you said it was an initial encounter for, okay, initial encounter for a closed fracture. I'm just referring to my book here.
Oh yeah, take your time. I knew this would kind of put you on the spot, but I do think it'll kind of
Yeah,
illustrate for.
yeah. Okay. 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 Oh, wow. There are just so many codes. So, even when you say closed fracture, it's asking me, is it a green stick closed fracture? Or is it a displaced transverse fracture?
Let's say it's a green stick.
Okay, so if it's a green stick, that would be S52.312.8. So that's green stick fracture of shaft of radius, left arm, initial encounter for closed fracture.
Okay, and is there an extension code or like something that comes in to show that it's from an accidental fall then?
Um, no, no, it
Okay.
stops here. And then you would be putting an E code. It's not an extension code, it is a required code which where you have to define. So this is this will be a separate code altogether, which will be the accident code. It will not be a combined code.
Okay.
So now if it's an accidental fall, say the patient fell from a bike, from a tree, how did he fall?
He was out climbing a tree.
Okay, so accidental fall, climbing tree, there is a code for that. So in addition to the fracture, I would also put accidental fall, climbing tree. Okay, let's see.
Okay.
Fall from tree, initial encounter would be W14.XXXA. So obviously there is no severity and all of that. It's just fall from tree that we are documenting. So we're using the placeholder with the XXX, right? And an accident cannot be used as a primary diagnosis. The primary diagnosis would be the fracture, followed by the cause of the fracture, which will be fall from a tree, which is W14.XXXS.
Okay.
Oh, you know
Very.
what? This is fall from tree sequela. We are looking for initial, right? We're not. Okay, fall from tree initial encounter is W14.XXXA. That's the initial encounter.
Okay.
Yeah.
So I had some other scenarios, but I think I'll hold off on those because I think
You
this
could email
one.
me, Eric, and I can give you the code. See, any common codes that your NPs come across, I could help you with zeroing in on those codes.
Okay.
Yeah.
But I do think this one case certainly illustrates the level of documentation that needs to be present so that when, you know, the chart does get to the coders, that they can interpret, you know, what needs to be translated into a code easily, and so that it helps support documentation with the coders not having to come back to the clinician multiple times to get additional detail that the clinician may or may not have at that time.
Exactly.
So, yeah, it's certainly clear to me that it is a level of specificity and complexity that wasn't there before. So I do appreciate the webinar and the examples that you've provided. So thank you very much.
And thank you for the opportunity, Eric.
As we move forward, you and I can talk about additional handouts that may supplement student learning, but I hope the students and faculty will find this webinar helpful in making the transition from ICD 9 to ICD 10. So thank you very much.
Thank you. Thank you so much.